Okay, so this presentation is on blood flow restriction training for the upper extremity, current concepts as of 2024. So within this presentation, we'll be focusing on the background and the science of blood flow restriction training. The following 9 questions are those that which will be covered based upon the content presented. So what is blood flow restriction training? Why would I use it or consider using it in the clinical setting? Who can benefit from it? What does the evidence say about the effectiveness of blood flow restriction training? How does it actually produce the said adaptations? Is it truly safe? And for who? What are the risks and the side effects of BFR? And how do I know if my patient is appropriate? Within this, we'll also discuss briefly the practical and the clinical applications. All right, so first the introduction, defining the problem. All right, thinking critically about the current situation, that is, what is rehabilitation and what are the mechanisms by which we get people better? Grossly, we can think of this as joint mobilization, strengthening, movement patterns, muscle endurance, improving people's quality of life, providing education, working on people's balance and their overall flexibility perhaps. But really more on a granular level, the mechanisms by which we induce changes and physiological adaptations, promote recovery, and help people to be able to have a greater physical capacity than when they first come in to see us is really through mechanical biology and mechanical transduction, through the stimuli that we induce by the exercises, the mobilizations, the modalities that we implement. And oftentimes, as the name entails, this requires some form of mechanical stimulus. And this is in line with the mechanical stress theory presented by Muller et al. In 2022. Right, so in this first figure on the left, there's the effect of prolonged low stress, which lowers the thresholds of subsequent adaptations and thus also predisposes someone to injury. The physical stress is on the y-axis and you have the baseline condition, and you can see that due to either aging, injury, immobilization, lack of training, so on and so forth, deconditioning of sorts, that you have lower threshold points for not only atrophy, maintenance, the increased tolerance to physical load or mechanical stress, and thus reducing the threshold at which injury can otherwise occur. However, on the right-hand portion of the screen, right, so with youth, rehabilitation, ongoing physical training, and incremental general adaptation syndrome, that is the adaptations that come with stress followed by periods of rest and recuperation, that we get higher set points, higher thresholds, where it takes more activity or more macro stress to otherwise induce injury. Thus, you have a more resilient biological system. Now, that's all fine and good, but the problem is with rehab and injury comes increased pain, increased inflammation, a decrease in tissue integrity, a decreased threshold to mechanical stimuli that could potentially cause further injury. Secondary implications of the injury and the immobilization, right? So you have increased muscle atrophy within 5 days of immobilization, a decrease in muscle strength, almost 15% reduction after 14 days of immobilization. That increases to 21% after 23 days, where you ever get also a reduction in muscle endurance and power. Tendon cross-sectional area as well as stiffness reduces by 30% within 3 weeks. There's also neural adaptations. The neural excitability is reduced, as well as a neural drive as little as within 7 days. So with the problem that we face within rehab and the inability to adequately expose the biological system to mechanical stress, then we have to seek alternative means or creative means. Certainly you could use the natural history progression and essentially wait it out such that the tissue's inflammatory process, pain, etc., is less, and thus the person could otherwise tolerate a little bit more mechanical stress and gradually expose them to that, which is the process of rehabilitation as it traditionally stands. However, this can be quite drawn out and extended. And if there's a way or ways in which we can otherwise expedite this, then it would behoove our patients as well as us to do so. So a potential solution is the application of blood flow restriction training that doesn't leverage the necessity of high mechanical stress, but rather induces a metabolic stress to the system at which we could utilize only a fraction, specifically 20 to 30% of the same mechanical stimulus or tension, particularly when it comes to mechanical load or external loads, or even internal loads for that matter, via high muscle volitional contractions. We can induce comparable results. So the figure here, if we just to orient you, right? So you have the starting at the top, you have that gray band, which is a deflated cuff, and you can see that there's equal flow in and out of the limb. The arterial flow demonstrated by the candy cane striped arrow, and then the clear white arrow of the venous flow back. And then you have a cross section of a muscle that shows the little different circles. So the grayish circles are the active muscle fibers, whereas the or motor units, you could think of them as well. And then you have the different motor units that are associated with that. So the active versus partially active, and then the inactive motor units. And then the little stars indicate the metabolites. So then with the black stripe now indicating an inflated cuff, and thus you can see there's a reduction in the arterial inflow, specifically by 80% or potentially 50%, depending on whether we're talking about the lower extremity or upper extremity respectively. And then there's a complete reduction in the venous outflow. Thus, you can see the increase in the number of metabolites, indicated by the little stars. And then there's also an increase in the intensity and the number of active motor units and fatigue motor units now that have also been presented. As time goes on and the exercise continues under this condition, then we get a gradual increase in all of the above. There's increased metabolite buildup, so hyperconcentration of hydrogen ions, lactic acid, CO2, deoxygenated hemoglobin and myoglobin. As such, this hypoxic environment that's created because of the reduction in inflow of O2 via the arterial flow and the lack of being able to clear the metabolites and the CO2, then you get an increased exponential recruitment of motor units, and thus there's more fatigue motor units now. All the motor units are otherwise active within the muscle under a given stimulus. And then finally, as the exercise climaxes over, hopefully within the fourth set, or maybe you're doing aerobic conditioning, which we can talk about, is that the ideal scenario is where all motor units become fatigued by the end, and there's a hyperconcentration of metabolites throughout the muscle, as well as within the interstitial fluid. You get a scenario of cell swelling, and thus you get a strong stimulus, what would otherwise take an exceeding amount of additional mechanical stress or an exceeding amount of metabolic stress and aerobic stress to otherwise induce, that we were able to expedite the process of fatigue in a relatively short time point, usually within a single exercise, anywhere between 8 and 15 minutes. And that is the overall arching mechanisms or theory behind the blood flow restriction training, and the value that it can otherwise have in inducing some of the physical adaptations that we can't otherwise induce because of the problem and the reduced integrity, the reduced mechanical tolerance, the increased pain and inflammation that comes with injury and or immobilization. With that in mind, let us go into defining what blood flow restriction training is. So there's the perception for some that blood flow restriction training is rather new, and thus with something that's novel and untested, there can be some hesitancy of acceptance. And so I think it's worth just taking a moment in acknowledging the history of blood flow restriction training. It's been around, though not by the same name, as early as the 1950s, where there was the initial early observation where BFR was explored, not specifically for muscle training, but early studies focused on limb occlusion for various medical purposes. In 1966, the invention of Katsu training by Dr. Sato in Japan developed the concept of Katsu training. He noticed cell swelling and discomfort from prolonged kneeling and being in what would be prayer and or meditative positions. This led him to experiment with blood flow restriction training under the name of Katsu training to enhance muscle growth and strength. And then in the 1970s and 80s, Dr. Sato continued to refine Katsu training, developing specialized cuffs and protocols. The early research was primarily conducted in Japan, focusing on the safety and the efficacy of the technique. And then it wasn't until the 1990s where there was expansion into the scientific community where BFR training began to gain attention outside of just Japan. Early studies explored its potential benefits of not only just for muscle strength and muscle swelling as shown by Sato, but also for muscle hypertrophy and using it with deliberate low load exercises. And then in 2000s, it really began its expansion. Numerous studies were being conducted to explore the mechanistic and the benefits of BFR. And then the research expanded to include applications in rehab, sport performance, and various medical conditions. And then by 2010, widespread adoption of BFR training, gaining popularity in sports medicine and physical therapy. Standardized protocols in commercial BFR cuffs became more widely available. And research continued to be validated in its effectiveness in muscle hypertrophy, strength, and rehabilitation. It really gained traction within the United States through the Center of the Intrepid, through the Department of Defense in Houston, Texas. And that's was brought by Johnny Owens as they tried to rehab men and women from the military after blast-based injuries or combat-based injuries, and returning them either back to combat, to civilian life, and for limb preservation. So they were struggling to be able to return the muscles back to the same adequate performance, even though the joints had gone under preservation. They were still load-bearing sensitive and mechanically sensitive. And so it first started in the military, then gained traction within the sports medicine, and then now more pervasively considered the standard of care in rehabilitation. So to provide an actual definition for what BFR is, it entails the application of a tourniquet style cuff. These days they're predominantly pneumatic cuffs at the proximal portions of the limbs. That is as close to the axilla or as close to the groin as you possibly could get for the upper and the lower extremity respectively. The cuff is tightened, again, pneumatically through inflation that occludes the venous flow yet allows arterial inflow to the limb. And more science has otherwise substantiated the importance of this pressure being specific not only to the limb, that is left versus right in the laterality, but more importantly to the individual specifically. And occluding in the upper extremity, it's going to be 50% of your limb occlusion pressure, and in the lower extremity, it'll be 80% of your limb occlusion pressure would be the standardized protocols, but there could be variation there within. And limb occlusion pressure is the pressure to completely stop both venous and arterial flow. So you can think about this broadly into active and passive applications of blood flow restriction training as far as the current science is concerned. So there's 3 different forms of it, broken up amongst those 2 broader categories. So you have the load compromised or clinical population that has been studied, the load compromised clinical and healthy population, and then the actual athlete and healthy population. So there's the established methods and then the developing methods. Let's take a closer look at the established methods, which would be for your load compromised or clinical population. There's the application of blood flow restriction training for low load resistance training, as well as low intensity aerobic exercise. Again, the demonstration here is for the lower extremity, but it could be applied to the upper as well in both capacities. When we look at the developing methods, we can see that for the load compromised in clinical populations, that there's high to moderate intensity aerobic exercise that is currently under development, as well as IPC or RIPC. This stands for ischemic preconditioning or remote ischemic preconditioning. Remote ischemic preconditioning, meaning that the cuffs are being applied at a certain location, but with the intended benefit being elsewhere within the body, be it for, they've looked at this for the heart as well as other organs, and then they've also looked at it from an athletic performance standpoint. When we look at the load compromised clinical and healthy individuals, there's also developments being made for the during rest or immobilization, neuroelectrical, in combination with the neuroelectrical stimulation. And then more for the athletic population, they've looked at this under high load resistance exercise, sprints and repeat sprints, and then even with the application of certain sport-specific training or technique training for athletics. And so this gives an overall arching framework as to what are the established methods. You can see that not only in different populations, but also in different intensities and different contexts that BFR is continuing to expand. And what it is, let's look at the indications of blood flow restriction training. Why would one consider using BFR, either on themselves or on a client or patient, and who is most appropriate? So the indications of why BFR should or could be applied or justified. So multiple different systems, specifically 6 of them listed here. Though this may not be an exhaustive list, it's certainly quite comprehensive as far as where the science currently sits. So if we take them each in turn, let's look at the cardiovascular system. So blood flow restriction training can significantly increase peak VO2 max by 4 times as compared to controls, increase someone's heart index by 70%, improved arterial compliance, increase the time to cycle exhaustion by 15%, increase peripheral vasodilation and thus the compliance of the arterial system and its ability to vasodilate and vasoconstrict. Increased hypoxia-induced factor 1 alpha, which leads to vascular endothelial growth factor. That is the hormone that is used to promote angiogenesis, or the neovascularization and the sprouting of new blood vessels, thus increasing the blood flow to a particular limb or body region. It also decreases systolic blood pressure. That is more of a chronic adaptation and it also improves heart rate recovery in hypertension based demographics. In regards to bone, acutely bone specific alkaline phosphate and osteocalcin, also known as BGP for short, have shown to increases bone mineral density and bone microstructure over time. That's with the presence of low load as compared to low load resistance training, and it also increases the preservation of bone mineral density and bone microstructure, as well as muscle mass in bone stress injuries. When you look at the metabolism, it helps to upregulate GLUT4 expression and glucose uptake into the muscle. So your GLUT4 transporters are the channels on the outside of the muscle that you can think of why the muscle serves as a sink for circulating glucose, and thus improves one's metabolic profile in regards to resting blood glucose levels, as well as the insulin sensitivity. It increases mitochondrial biogenesis and density, as well as function. It increases mitochondrial prosynthesis rates and oxidative capacities. For the nervous system, BFR can be applied to increase one's EMG by 50% as compared to low load resistance training. It decreases short interval intracortical inhibition, which is essentially the inhibition that comes down from the central nervous system, thus allowing for better activation of motor units. Increased neuromuscular fatigue via group 3 and group 4 afferent fibers. Increased corticospinal excitability, which leads to an influence in force capacity of the neuromuscular system, which leads to long-term changes in recruitment patterns, a decrease in pain, and an increase in exercise-induced hypoalgesia. Though the muscular system certainly gets a lot of highlight when it comes to blood flow restriction training science, and really because that's kind of the realm in which it started and where the benefits were most prominently noticed first, we can see that it's no longer just for muscular adaptation, but the benefits here are vast. It increases type 2 muscle fibers and EMG of the muscles being recruited, as well as those proximal to the limb, depending on the extent of that is the intensity and the volume of the exercise. Increases muscle hypertrophy and strength and endurance. Increases the activation of muscle stem cells and the recruitment of those, thus for muscle hypoplasia, that is the growth or the expansion of muscle cells. Increase muscle ATP and glycogen stores to improve muscle endurance. The GLUT4 translocation and glycogen synthase activity, as I mentioned during the metabolism, but this also benefits the muscle. Increase tendon cross-sectional area and stiffness as compared to high load resistance training, and then also decreases pain and increases tendon function in tendinopathies. And then finally, in the endocrine system, which really affects all the other 5 systems that we've discussed, with the application of blood flow restriction training, particularly with resistance training, but can certainly see an increase during aerobic exercise as well, is that growth factor increases by 290 times within an acute response. Cortisol levels increase, as well as the stimulation of IGF-1, which then helps to increase the stimulation of mTOR and the protein synthesis. Increased testosterone levels with acute elevation similar to that of the growth factor, and then the growth hormone, and then you have the increased VEGF, which similar to what we had mentioned with the cardiovascular system, this promotes angiogenesis and neovascularization, which increases blood flow and volume to the occluded limb. So in that last slide, we spoke about all the more cellular and the granular means by which blood flow restriction training can help the biological system and the different individual systems themselves. On a more pragmatic level, as far as a patient demographic, who can benefit from this? Well, your individual soft tissue injuries, as we spoke about, not only the muscle, but also the tendon and the connective tissue benefits that can be seen. Proximal injuries, particularly for the upper extremity, has been shown to be beneficial not only for the upper trap, deltoid, pectoralis muscle, and we'll explain some of that research moving forward. Fractures, obviously, with the benefits of the that was shown in the last slide in comparison to the low load resistance training, or that being said, just immobilization on the whole, that we can get positive bone mineral density adaptations and preservation of bone with the application, even in the immobilized limb. Post-surgical, certainly this is going to, if there's anything that can be beneficial for healing, it's going to be the delivery of nutrients, and the better the blood flow is to a particular region, the better the outcomes can be. Obviously, choose your patient demographic, and certainly we'll go through some of the screening precautions that need to be in place to ensure that this immobilized limb and individual can tolerate and is appropriate for it, but this is critical. I'll use the example from the lower extremity that within the first 2 weeks, on average, people lose about 350 grams of muscle mass out of their quadricep post-ACL. What is 350 grams? It's about the size of the human heart, which is 300 grams. And that's not, we're not talking about strength, we're talking about the loss of viable muscle mass, which is really essential real estate that is not easily recuperated. In fact, depending on the age of your individual, that can take 6 months to a year to recoup. That being said, your deconditioned and atrophied individual, or those individuals that are experiencing atrophy, certainly, or those that are at a anabolic resistance, such as your older adult, can significantly benefit from any anabolic stimulus to help to promote the healing process. And then certainly similar to your fractures and your post-surgical, your immobilized individual, where we can start to use ischemic preconditioning at the very least. That is the application of blood flow restriction training at 100% limb occlusion pressure with no exercise, or potentially even passive ranges of motion. But in the immobilized patient, just the IPC that would be somewhat valuable as far as preservation of the lean muscle mass. Okay, we're still thinking now about no longer necessarily about why, but who. So the number of demographics that blood flow restriction training has been applied continues to rapidly expand, as indicated by the slide just a couple back, where I was talking about the developing and the expansion of blood flow restriction training. Here's not an exhaustive list, but a quite extensive list of the different demographics in which it has been applied. And I'll go through a couple of papers. Blood flow restriction training blunts the chronic kidney disease progression in humans. Let's talk about sex. So the application of BFR in females is gradually increasing. Does blood flow restriction training in patients older than age 50 result in muscle hypertrophy, increased strength, and greater physical function? Spoiler alert, it does. When we look at that in athletes, which I had alluded to previously in sport-specific training, the idiosyncratic bone response to BFR and new insights and future directions for not only just fractures, but also bone stress injuries. Thinking about our metabolic responses and benefits, our type 2 diabetes, as well as with our getting people active and increasing the metabolic response and the metabolic stress that comes with it, the effectiveness on neurological diseases and neuromuscular diseases. Again, in the older population, another systematic review that has considered this. When we look at the ACL and the adolescent post-operative patient, there's been benefit shown here as well from those at Connecticut Children's. The effects of BFR with resistance training in musculoskeletal health in older adults. When we look at the hypertensive patient, which some would immediately kind of raise their eyebrow at as far as the them being contraindicated, but yet this is a demographic, if properly executed, can significantly benefit, as we spoke of the benefits that it can have on the cardiovascular system, one in particular, the reduction in systolic blood pressure, and the increase in compliance and the ability to improve vasodilation, the role of blood flow restriction training in chronic obstructive pulmonary diseases, and then also with the more novel coronavirus and the postoperative deconditioning that can come from that condition. And then certainly with those individuals that are in a microgravity environment where there is no means of mechanical stress, well then metabolic stress on the biological system can certainly be beneficial, and thus it's also found its way into space flight. And then more recently, they've started to really kind of push the envelope of novelty with its application in heart disease and heart failure. And then looking at the tendon rehabilitation, as I mentioned, the connective tissue benefits go extensively beyond that of just the muscle. And then even considering the increased lactate that response and the hyperconcentration of metabolites, is that there's also shown to be cognitive and neurocognitive benefits from BFR. So again, the applications continue to expand, and the utility of it obviously still needs to be validated in some of these demographics, and certainly am I not indicating that your first application should be on a heart failure patient or those of hypertension. However, I will say that if properly applied, and if you really understand the science behind it, and certainly some researchers and clinicians have shown its efficacy in these demographics, that there can be a whole host of people that can potentially benefit from this supplementary modality to what your standard of care is. So we know potentially why we would want to do it. We would know potentially the different demographics on who we could do it to or with, and then what is the effectiveness? Is it really is the juice really worth the squeeze when it comes to the application of BFR? So looking at the evidence of blood flow restriction training, my disclaimer here as we go into the science and the literature is that in the last couple of years, specifically the last 2 decades, the rise has been exponential. And so what I will be talking about today will be only really a subset of this, but I will try to give you the most comprehensive pulse on the current landscape and what the evidence has to say as possible. Piggybacking on this, if you look at review papers in themselves and you filter by that in regards to the bibliographic analysis in PubMed, we can see that there's been 99 review papers in just the last 10 years. And then of those, about half of them are systematic reviews that have also just been published in the last 10 years as well. And so the fact that there's that many systematic reviews is, one, just incredible, and two, speaks to how many additional independent studies and individual studies that have been conducted during that time. So with the current expansion and exponential increase in the research, today's webinar and presentation will focus predominantly just on the tip of the iceberg. You're welcome for that, because otherwise we'd be here for a very long time as far as talking about all the evidence and all the different papers that have been published on it. So we will do our best to give you the landscape, you have a really good feel as to the confidence as to the effectiveness that it has in the clinical setting on a different demographics that we've already briefly touched upon, with a particular emphasis on the upper extremity. All right, so with those disclaimers and contextual factors out of the way, let's focus on the literature reviews specifically. Okay, yes, this one's a little dated from Lenicky in 2012, but it's considered to be a seminal paper within the literature of BFR. It's cited 91 times in the last 10 years. So the population of the systematic review was healthy, untrained individuals, recreational, active individuals, as well as athletes. There were 11 studies that were included. Only lower extremity BFR were included because at the time there was minimal to no upper extremity. They specifically mentioned that within the methods of this systematic review. The methods that were performed were not only systematic review, but also meta-analyses and the pooling of the data. And then the outcomes they were looking at were muscle strength and muscle hypertrophy. So I've graphed the outcomes here as far as effect sizes. So the effect size as given by Cohen's D is shown on the y-axis, and then you have the exercise group, low load resistance training versus low load resistance training without BFR. You can see that by far and away that the effect size here is not only statistically significant, but also clinically meaningful as far as the benefit. And we can note, y'all, just like a reminder, right, that 0.2 is considered to be a mild improvement, where 0.5 is being more moderate improvement as far as the effect size is concerned. And this is specifically for the effect size in cross-sectional area of the muscle, so the muscle hypertrophy. For muscle strength, it's that much better, right? So we're at 0.5 now on the effect size, and still 0 to nil in regards to the control group. And again, just using 20 to 30% of one repetition max, the fact that we're getting these meaningful changes is quite, was at the time, and still looking back at this, is quite convincing for the potency that this modality can have for muscle adaptation. So Lenicky and authors concluded that BFR resulted in significant greater gains in strength and hypertrophy when performed with resistance training than with walking. That's not necessarily a surprise. Lower extremity BFR 2 to 3 times per week really shows to be the sweet spot as far as minimal effective dose, with the greatest effects, gave the greatest effect size compared to 4 to 5 days per week. Significant correlations were found between the effect sizes for strength development and week of duration, but not for muscle hypertrophy. And I'll show a figure here in a moment that can kind of help to visualize that and the timing of the adaptations. Okay, so on the y-axis you have progress, or you can think of it as physiological adaptations. Across the time, across the x-axis you have time, and we're looking at 3 different adaptations. We're looking at strength, we're looking at neural adaptations, we're looking at hypertrophy. And we're looking at this as in comparison in the context of low intensity, that is LI-BFR or TRT, or traditional resistance training. So when we first look at the hypertrophy, right? So low intensity BFR being the dashed line, traditional is going to be in the solid. What we can see is that when it comes to muscle size improvements, that the low intensity BFR has an exponential increase in muscle hypertrophy and size early on, and then if you were to continue with these over chronic adaptations, that eventually the high load resistance training would potentially surpass that of the low intensity resistance training group. With strength training, it's actually reversed, right? If you can load heavy, you should be loading heavy. But that being said, if you load low, right, you're not going to see any strength improvements, as we saw from the systematic review and the effect size of 0 from Lenicky. And so here, the traditional resistance training is going to have a linear increase, presuming this is an untrained individual, and there's going to be more of a sinusoidal curve in regards to the strength improvements for low intensity BFR. And then finally, the neural adaptations. So neural adaptations are going to gradually and rapidly increase for the traditional resistance training, and then gradually increase for the low intensity BFR. But eventually, because of the metabolic stress and the potential ongoing chronic changes that can occur, as well as the benefits from the lactate concentrations, the growth factor and growth hormone, so on and so forth, is that it's speculated that the neural adaptations may have some superior benefits as far as the BFR group is compared to the traditional resistance training. And I think that as what we eventually will see is that, yeah, we always like to compare what is the best as far as, whether it's tendinopathies and we're talking about eccentric versus isometric training. But I think in reality, it's the hybrid approach. I think that what we'll see when it comes to performance and the mixed model application of BFR and high load resistance training, be it in the middle to later half of rehabilitation or as we phase people back into high level sport and performance or whatever the recreational endeavors that they're trying to get back to, that the application of both these modalities of high load resistance training as well as BFR certainly have their place. Then specifically for the visualization of the effect size and the time component that was listed there in the conclusion. So in the green here, you have muscle strength. In the navy blue, you have hypertrophy. On the y-axis, you have the effect size, and then you have time running across the x. And so you can see within the first 6 to 8 weeks is that there's a moderate increase or consistency in the strength as well as in the hypertrophy, and the hypertrophy does take a little bit longer as it gradually exponentially increases through that from around that 6 to 8 to 10 week time point. And the recommendations here are trying to, if you're going to put a protocol into place at 6 to 12 weeks of BFR, those types of studies certainly seem to have the better effect size, and understandably so, because you're able to have more chronic changes that adapt, and hopefully there's progressive resistance associated with that as well. And the effect sizes here are quite substantial, right? So you're well over, by 10 weeks, your hypertrophy is well over 1.0, which again, the average effect size for rehabilitation modalities or interventions is about 0.5, which we see that pretty consistently across all weeks for the muscle strength. All right, next systematic review, more recently, so 5 years later, Hughes did it, but no longer in a healthy population, but he's looking at a clinical population. There was 33 studies, 15 randomized controlled trials, 18 non-randomized controlled trials. The demographics included knee OA, ligament myositis, older adults as well. Again, you'll notice that there's no upper extremity associated with this. Unfortunately, again, they stated within their methods that though they wanted to include it, there just simply weren't the studies available. However, the purpose of including the systematic review in particularly amongst all the other 49 that have been published in the last 10 years is that this was the first one that was done on the clinical population, and it has 20 studies included within the meta-analyses. It was done by a premier researcher, Hughes, who consistently is all over the BFR research. Outcomes here, they looked at muscle strength, muscle hypertrophy, pain, as well as physical function. So looking at muscle strength first, so they categorize their outcomes using a forest plot. So the low load resistance training to the left of the 0 point line, and then the low load resistance BFR group. You can see that the little diamond falls to the right of it, supporting the BFR over the low load resistance training in regards to muscle strength. When we look at muscle strength in regards to low load versus high load, once again we see high load BFR. One caveat and change that you'll see in some of these systematic reviews, if you look at the more common ones, is that there's more of a minimal effect as far as the difference between low load BFR and high load BFR. And one of the speculations of that is the method by which they're considering max strength. So typically in the earlier studies, the low load resistance training, low load BFR group just was not exposed to high load resistance training. And the reason being, one, at least in this case, being the fact that the rehabilitation, but the other consideration is just because of their group allocation. And then, so when you go and test their strength at the end, a dynamic 1RM has different, necessitates different physiological adaptations that does the low load resistance training group in particular. But more recently, when you look at the systematic reviews, these have shown to, as I mentioned, to be more equivocal as far as no significant difference between the two groups. And that's in part due to, and this is per Johnny Owens, the CEO and Director of Education at Owens Recovery Science, and really the man who's really been responsible for the expansion of BFR within the United States and within the rehab and the DoD. And his speculation is because a lot of the post outcomes now are looking at what is the true maximal strength that someone can produce is not through a dynamic 1RM, but really through isometric and static force output. And in that case, in those cases, it shows that there's really no significant difference. Granted, it's going to be dependent upon the demographic, the contextual factors, etc. But that would be one explanation for what you see here from Hughes, as well as some of the more newer systematic reviews and meta-analyses that have compared this, and why you get some discrepancies in the results. From Hughes, low load BFR in musculoskeletal rehabilitation setting in clinical populations is effective at attenuating strength loss and facilitating strength in clinical populations suffering from musculoskeletal injuries. It can increase muscle size and strength adaptations, may act as a surrogate for heavy low load strength training, strength rehabilitation training in a broad range of clinical populations, and is safe when proper screening, individualized pressures are used, and there's a graded exposure to the program is applied. Additionally, BFR offers added physiological adaptations beyond just the muscle. The stimulation of mTOR complex 1 signaling and muscle protein synthesis in older adults. Blood serum levels increase bone alkaline phosphatase as well as bone turnover, which leads to increased bone health. There's increased carotid arterial compliance, peak oxygen uptake, peak post-occlusive blood flow, and vascular endothelial function, as well as the peripheral nerve circulation. And those adaptations in that final bullet point come from those that applied BFR with walking and aerobic exercise. It would be recommended that there should be a systematic progression with BFR. The proposed progression would look something along the lines of BFR alone during the periods of bed rest or immobilization, BFR with passive range of motion plus or minus NMES, BFR with low load workload walking exercises, BFR then combined with low load resistance exercises, and then eventually the hybrid approach of low load BFR in combination with high load resistance training. Again, proper screening and stratification of patients, as well as the individualized pressure, is going to be critical. And as I alluded to, the longer duration studies or protocols or programs of BFR are going to be more effective, those lasting greater than 6 weeks. Though being said, right, BFR is really just a bridge to being able to do traditional high load resistance training. Certainly, again, there's means and potentially plausible additional future research that would show its the added benefit that BFR can have in the presence of those later stages for certain specific adaptations that you can't otherwise gain as readily during high load resistance training. But really, for the most part, it is a bridge to being able to get mechanical stimulus back into the biological system. Okay, and this one is included particularly because of its size, right? So and because it's more of an update to that of Lenicky. So you have healthy adults, 47 studies, RCTs and non-RCTs, including studies that had 27 of them were just male, 7 of them were just female, and 14 of them were both. You had over 400 subjects, average age of 34. The meta-analysis was the largest to date with 28 studies. And again, it looked at muscle strength and muscle hypertrophy. And it also included and categorized the studies into cardiovascular as well as resistance training. So muscle strength as well as muscle hypertrophy. Once again, the diamond falls to the right of the midline, and we can see that for the resistance training results is that muscle strength and muscle hypertrophy favors the low intensity BFR group. The effectiveness of BFR for aerobic training. So we can see that once again that both for muscle strength and hypertrophy, that doing aerobic training in the presence of BFR is better than not doing that, at least for low intensity exercise, particularly in the demographic that was otherwise selected here. All right, and then the more recent systematic review that was conducted, and the purpose for including this one because of the recency of it. The second is because it looks at the older adult, and so there's often a bias or in regards to BFR being really more for your young, your healthy individual, but that's really just not the case. It can be safely and effectively applied in your post-middle-aged adult, and here's a systematic review and meta-analysis to demonstrate that. So muscle strength compared to just normal activity, there's a rather significant and unequivocal benefit favoring the low intensity BFR group. When it comes to muscle hypertrophy in comparison to the control group, once again there's a favoring of the low intensity BFR. Granted that the diamond here does seem to cross midlines, thus the effect would otherwise suggest that it's unequivocal between the two groups, but certainly leaning towards the BFR group. And then in regards to muscle strength, so they looked at they specifically looked at the studies that did it 3 times a week versus twice a week, and 3 times a week showed to actually demonstrate a meaningful difference favoring the low intensity BFR. So it looks like there to be a frequency and dose response relationship, that 3 times a week being important for your post middle age adult, if the desired adaptation is muscle strength. And then muscle strength as compared to the low intensity BFR versus your normal activity, once again favoring the BFR group. And this is kind of what I was alluding to earlier, where when you compare the low intensity BFR group in regards to that of high intensity resistance training, that the diamond falls almost directly on midline, suggesting that low intensity BFR is just as effective as the high intensity resistance training when it comes to muscle strength. Okay, and finally, the effects of upper body BFR training on muscles located proximal to the applied occlusion pressure. A systematic review and meta-analysis. So this was healthy individuals across 9 studies that met the inclusion criteria, and they conducted both a systematic review and meta-analysis. First, looking at muscle strength, right? So all the evidence thus to date that has been presented, at least in this webinar/presentation, have been more on the benefits of muscles distal to the cuff. However, this is the first one that we're considering where we're looking at the benefits proximal to the cuff, and with the upper extremity, right? So because the cuff goes to the goes on the just under the axilla, close to the essentially close to right where the deltoid inserts and the proximal portion of the bicep. Then the chest press would be muscles, though certainly the shoulder and the tricep, as well as the pectoralis muscle, show to favor the low intensity BFR as well as the shoulder flexion. Again, really encouraging results for not just distal but also proximal gains when it comes to muscle strength. And then when we look at this in regards to high intensity resistance training compared to the low intensity resistance training for those same two exercises, we see that there's comparable, though a slight favoritism to or leaning indication towards the high intensity resistance training group. The diamond pretty much splits the midline, suggesting that there's no significant difference really between the low intensity BFR group and high intensity BFR group for muscle strength, at least with these two particular movements. In regards to muscle hypertrophy, so no difference between the low intensity resistance training plus BFR was observed in the pectoralis muscle size, thickness, or girth in 3 studies that implemented only the chest press exercise. And the explanation for this, that proximal muscle size adaptations may be plausibly driven by the total time under tension, a minimal volume threshold, and training period, and or a systematic effect rather than just specific the specific exercises performed. And so with this volume threshold, we'll see this later in the presentation when we get into this individual studies, but the total time under tension as well as the volume and the intensity and the time period and the training period, what we see over time is that there's this upstream effect that occurs due to the fatiguing motor units that are being predominantly occluded, and thus you get gradual progressive increases in the EMG activity of the proximal muscle groups, which then drives the adaptation of not only the strength benefits that we saw, but also the muscle hypertrophy. And in this case, one of the plausible reasons why there wasn't more significance shown with the muscle hypertrophy is because the sensitivity of the muscle size measurement methods were inconsistent and may have played a role in the findings. A significant effect for the lower extremity BFR was observed only in the shoulder lean mass compared to the low load resistance training as measured by DEXA. In contrast, some of the other studies only looked at this with ultrasound or a tape measure, which is really just kind of a too gross of an assessment to really be confident that those size changes or circumference changes are really truly due to lean tissue changes. All right, and so sticking with the same systematic review and considering the risk of bias. So unfortunately, the quality of, and which is, I guess maybe not surprising with any new venture into a particular different paradigm of research, that it takes a while for researchers to really refine the methodological rigors and to get proper funding and so on and so forth to be able to really conduct high quality studies without a risk of bias. But really, when you look at both the Pedro score as well as the grade or quality of evidence, that unfortunately across the board, all 9 studies showed to have some either high risk of bias or low quality as far as the grade of evidence is concerned, and thus would be suggestive as to, maybe not surprising, but the recommendations are for more high quality research to be done when it comes to the upper body blood flow restriction training, in particular where it applies to the proximal muscle groups. Okay, so that last study looked at proximal muscle group, the proximal applications and benefits. Let's look at distal and proximal. So we have 19 studies in this systematic review for Dankel et al. And this they looked at muscle hypertrophy as well as muscle strength. So here you see the effect size Cohen's D, and then you have the different studies across the x-axis, and I've added in the labels for biceps hypertrophy as far as the data points as far as the effect sizes. And I spoke earlier in the presentation about the interpretation of effect sizes, particularly for Cohen's d. So just here's a nice chart that as a reminder. So how to interpret this. So the effect size Cohen's d. So 0.2 would be considered small, 0.5 medium, 0.8 large, and 1.4 very large. And then not only beyond just the interpretation, but then the percent of the control group, or the group at baseline as compared to the pre and post, that we would see that you could interpret this as a percentage. That so your interpretation would be, for let's take 0.5 for instance, that if there's a 0.5 effect size, then there's a 69% chance that that pre and post, that individual would be better than where they were to begin with, or better than the control. And you can see I've kind of color schemed the figure here to demonstrate really because it's kind of somewhat shifted with that 3.9 effect size, but really almost across the board, with the exception of maybe two of them, specifically Hunt 2012 and Thibault 2013, they all have medium, large, or very large effect sizes. And to keep in mind that what you traditionally do in rehab as far as interventions are concerned pretty much falls at this black line. So the fact that we're getting substantially, even double, triple effect sizes beyond that is quite impressive. So with the pre and post pectoralis hypertrophy effect size, once again, you have effect size on the y-axis, and you have the 5 different studies shown on the x. And then the interpretation, again, similar color coding to what we saw before. So anything over that 0.5 is at 0.5 it's considered moderate, and that's your average effect size for rehab intervention studies. And then when we look at triceps hypertrophy effect size, we see quite significant improvements in the pre and post, with the majority of studies being certainly over 0.2, almost all of them with the exception of 2 independent studies, and then significant improvements in the overall tricep hypertrophy comparable to that what we saw in the bicep. So then what about strength? So looking at the bench press 1RM effect size first on the right, we can see the color coding and the effect size there, where again the majority, if not all, the studies are having a small to moderate effect size. Again, this is proximal to the cuff, but when we look at the bicep strength, for instance, we see substantial and probably the best effect sizes, which makes sense. One, given the exercises in question of the different studies, but in particular, this is going to be the predominant muscle group distal to the cuff that is anti-gravity, and that similar to the lower extremity where we see better hypertrophy in the quadriceps versus the triceps, we see that also in the upper extremity with the anti-gravity muscle, that is the bicep, being substantially more than that of the tricep, and certainly the more proximal muscle groups. Yeah, so the conclusions here are that the low load resistance training in the upper body produces similar muscle adaptations to high load resistance training. This increases the adaptations that occur in muscles distal to the cuff, specifically the biceps as well as proximal, chest and shoulders, to the occlusion. The positive physiological adaptations of low load resistance training in the upper body appear to occur at relatively low loads, at 20 to 30% of 1RM, and relatively low pressures as compared to the lower extremity, where people are using, and clinicians and researchers are using, around 50% limb occlusion pressures versus the 80% or at times 60% limb occlusion in the lower extremity. So speaking about the limitations, though really impressive results from this systematic review, and the first one to be done in the upper extremity. The study size, that is the number of subjects, seems to be somewhat questionable as far as the power analysis. So the muscle strength and size outcomes measured with various methods also makes for the direct comparison across studies somewhat difficult. And could not be directly compared to one another at times. There's no quality appraisal of risk of bias that was conducted in the systematic review, and the effect size, at least it wasn't reported, and then the effect size not reported for the control groups, really more just simply for the intervention groups. And then I had graphed the mean, the mode, the standard deviation of the study size, so number of subjects in the included studies, right, with a mean of 11, most commonly at 10, plus or minus 4, and the range was anywhere between 5 and 21 individuals within each study. So certainly room for improvement as far as the recruitment, but again, what we often see is with any paradigm or discipline that is initially being studied that there's always room for improvement and perfection. Nothing that doesn't yet exist can't be perfected, and so we expect this to only further continue to improve over time. Okay, so what? So what is the big deal? What does all this mean? Because there's certainly a lot of talk, a lot of research, several systematic reviews that we've looked at in a rather short period of time. What are the practical implications, and how does this change practice on Monday? So low-load BFR with proper screening is safe and effective for a variety of clinical populations, particularly individuals rehabbing from musculoskeletal injuries, individuals with non-communicable diseases, i.e. type 2 diabetes, cardiovascular disease, neurodegenerative disease, chronic kidney disease, COPD, with proper precautions. They may also benefit from low-load BFR regimens. And then BFR offers a variety of positive physical adaptations, more than just the muscle-specific adaptations that were early highlights of what the benefits could be. Specifically, increase in bone turnover, increased metabolic function, the little powerhouses of your cells and of your biological system, your mitochondria. So it helps to promote more of those or generate more of those, improves the density of mitochondria within the muscle as well as improve function. Increases cardiovascular and peripheral as well as central adaptations. The specifically arterial compliance improves, which is a very important biomarker and physiological function of the cardiovascular system when we're looking at all-cause or cardiovascular related deaths as well as major cardiac events. Angiogenesis and the sprouting of new blood vessels via neovascularization, and then improved blood flow peripherally to the limbs of occlusion, particularly done chronically over time. And then incremental graded exposure and systematic progression of BFR with individualized limb occlusion pressures, with exercises that are an exercise dosage that is prescriptive and most appropriate for the individual at hand, with sufficient duration of greater than, it says 4 weeks, but we know that 6 weeks is superior, and then frequency of a minimum of twice, up to 3 times per week, as that one systematic review by Chang showed, will also assist in optimizing the physiological adaptations. And then moreover, we see that the low-load BFR, particularly in the upper extremity, improves muscle strength, muscle hypertrophy, improves pain reduction as compared to that of low-load resistance training. We have positive muscle performance improvements, not only in the distal, but particularly the proximal muscle groups, which is dependent upon the limb occlusion pressure and the duration of the occlusion. The training volume threshold, i.e. the proximity to muscle failure, which increases the EMG, which shows to be an important indicator that we're going to get proximal gains. The duration, again, greater than 6 weeks, with the frequency 3 times per week being greater than 2 times per week. And the methods of measurement, these should be consistent with DEXA, MRI being superior to that of circumference measurements. So that's a lot of talk. and I get it that it's important to understand the systematic review and really just a 10,000-foot view of the landscape of the current literature. However, there are individual studies that I do believe provide additional insight and value as to understanding the clinical application, the mechanisms, and the science of BFR, which we'll go through now. So the effectiveness of BFR. What does the evidence say about the effectiveness? We've gone through the literature review. Let's talk about the seminal studies. Okay, so this is a randomized controlled trial. The subjects included 24 healthy individuals, 10 males, 14 females, ages 26. They performed it two times a week for 6 weeks. The cuff was Owens Recovery Science, a Delphi medical unit. 60% limb occlusion pressure was used. The control had the cuff but without inflation. The exercises performed were external rotation and side lying, IR pulley in standing, biceps curls in standing, tricep extension in supine, and then prone horizontal abduction. The volume was the traditional 30, 15, 15, 15. Those are each independent sets, so 75 repetitions together, and it was performed bilaterally. So we really have a 2x2 group of experimental design based off, because though they performed the exercise bilaterally, they only had the cuff on one arm. So you have the BFR group that did the experimental limb as well as the contralateral limb, and then you have the control group that did both the experimental limb and the contralateral limb. And the outcomes that they were looking for were muscle strength and limb circumference. So what did they find? So when we look at grip strength, so you have the percentage change from baseline, and that's 10% improvement in the BFR limb. In the non-BFR limb, in the BFR group, you have a 6% improvement, and the controls lost 3% of their grip strength. When you look at shoulder strength, again, you're looking at percentage of changes from baseline. Once again, the dark maroon is your BFR limb, the pink or the red being your non-BFR limb on the contralateral side, and then the yellow being the control group. Consistently, what we see for scaption, flexion, and abduction is that the contralateral limb was clinically and statistically significantly different as far as a percentage change from baseline as compared to the controls. And these are rather substantial numbers if you take a moment to think about that. There's a 48% improvement, 39% improvement, and 33% improvement in the strength of the shoulder changes pre and post in just 6 weeks is quite profound in the BFR limb. All right, what about limb circumference? So percentage change, once again, you have the arm as well as the forearm. So I've broken it up on the y-axis to BFR limb, the non-BFR limb, and the control, so you can get a sense of comparing the different portions of the limb. Again, we spoke about the limitations previously as far as the limb circumference. That being said, yeah, that was the means by which they took the measure of muscle hypertrophy, and we're seeing 5, 3, and 2.5% for each of the cohorts respectively in the arm, and then more modest improvement in the forearm. Granted, we would expect that just being smaller muscle groups, but once again, we're seeing consistency in the results, not only in strength but also in circumference, that the BFR and then the non-BFR limb shows to be both superior to that of the control group, which is suggestive that this study affirms that low load resistance training with BFR on the upper extremity it can improve muscle strength. muscle hypertrophy, limitations obviously with circumference measurements as I mentioned, but this is on muscles proximal, distal, and on the contralateral side of the cuff placement, which is pretty encouraging and pretty cool to see. Okay, so we're looking at the effectiveness of BFR on eccentric versus concentric now. So this is by Hill, 2020. Study design was an RCT, 36 individuals. So they had eccentric BFR, concentric BFR, and a control group. Young individuals at 22 years of age, 3 times per week for 4 weeks, so rather just short time. They were using a Katsu band, 30 millimeter width, 40% limb occlusion pressure, and they were using this for isokinetic degrees per second for wrist flexion. And they had the eccentric, their outcomes were eccentric peak torque, concentric peak torque, and max volitional isometric contraction of the untrained arm. And the volume was the classic 4 sets of 75 repetitions bilaterally. And here we see the adjusted peak torque at weeks 0, 2 weeks, and 4 weeks. And within the red group, we can see that that is going to be the BFR group. The blue being the, the red being the eccentric, the blue being the concentric BFR group, and we can see significant improvements from baseline in both the 2-week and the 4-week time point, with the triangles being the control group. So when we look at the effectiveness of BFR over the different time points, specifically when it comes to the EMG amplitude, and so this is the outcome of max volitional isometric contraction, we have the eccentric group, we have the concentric group, and then we have the controls, which is the triangles. And keep in mind this is on the contralateral limb that we're looking at. Rather than the actual training limb, because the hypothesis was on the contralateral side. And within 2 weeks, there's a 13% increase in the EMG amplitude on the untrained limb, and we'll round it up to 23% improvement in regards to the amplitude of EMG activation on the untrained limb in the eccentric control group. What are the conclusions of the study? So it indicates that the low load eccentric BFR increased muscle strength over time. Increased strength were not contraction type specific, meaning that they improved both eccentrically and concentrically. And then the low load eccentric BFR provides a unique alternative to maintain muscle function in an untrained limb that may have application during limb immobilization and rehab exercises. So yes, there's benefit for ischemic preconditioning, that is a complete occlusion of blood flow on an immobilized limb, but there's also potential benefits for doing eccentric training with BFR on the uninjured limb, is what they're suggesting, as a means of getting potentially a cross-education effect and benefits to the immobilized limb that can't otherwise do anything on its own. All right, so the effects of BFR, low intensity concentric or eccentric training on muscle size and strength. Again, comparison of the contraction type. Now looking at the trained limb. So we have an RCT, 10 individuals. It was able to, because they have essentially the individual acting as their own control. So one upper extremity is eccentric, the other upper extremity is concentric BFR. 22, so ages of 22, 3 times per week, 6 weeks, Katsu training. They didn't individualize the pressure, which is a limitation. They just started at 100 millimeters of mercury arbitrarily, increased 10 millimeters of mercury per session until they got to 160 millimeters of mercury, which is quite extreme for the upper extremity, particularly with such a narrow band of 30 millimeters, but what have you. Anyways, so we have biceps 30% 1 RM based concentric strength was used for both limbs. EMG during their outcomes were EMG during the exercise, the biceps cross-sectional area on MRI, which is a rather robust means of determining lean muscle mass increase, and then isometric elbow flexion 1 RM increase with a handheld dynamometer, and they did 30, 15, 15 bilaterally. And so what did they see? So across the different sets, you're looking at the muscle EMG in microvolts per second, and we're seeing the concentric group in the dark circles, and then the open circles being the eccentric group. And we can see that the eccentric group is having a rather quite low EMG activity across even what should be the more exhausting sets of 3 and 4. As you can see that increases in the concentric group, and so that is the concentric group mean EMG increased by 81% over was higher by 81% compared to that of the eccentric group. Now the implications here I think are really important, hence the reason why I've included the study. One is that you'll see this in clinical practices, that people will often just, they'll take the path of least resistance. They will ride the eccentric down rather than particularly in the presence of the discomfort of the cuff occlusion, is they will not fully engage the muscle. As such, their EMG would otherwise reduce, similar to what we see here. But I think the other thing here, key takeaway, is the proper dosage. So when we actually look at the eccentric to concentric contraction ratio of elbow flexion, well, the eccentric strength should be 60% higher than that of the concentric strength on average. And so if both groups are using a 30% 1 RM in regards to the concentric strength, their concentric strength, well, that's significantly underdosing them. So one arm is doing 30% of its 1 RM, obviously concentrically, but the eccentric limb is working one only eccentrically, and at 18%, almost half of the 1 RM of the concentric group. So it's clearly shown in the EMG that they are not nearly as taxed compared to that of the concentric group. Look at the results of the cross-sectional area that corresponds to that of the EMG, where the concentric group had a muscle volume increase over 6 weeks. They increased by 12.5%, whereas there's marginal improvement, only 2.9% in the eccentric group. And then muscle strength, right? So there's an 8% increase in the concentric group pre and post, and only about half of that improvement in that of the eccentric group. So the conclusions here: concentric low-level BFR with elbow flexion exercises at 30% 1 RM increase acute and chronic changes in muscle size. Acutely, significant increases in cell swelling. Chronically, muscle hypertrophy, not just the swelling effect. And then the concentric lower extremity BFR with elbow flexion is sufficient at inducing an increase in isometric strength versus minimal significant improvement, if actually it was not statistically improved pre and post for the eccentric group. But this also speaks to the limitations of proper dosage of the eccentric and coaching the patient to actually volitionally engage the muscle as they control the weight down. Okay, so just as important as looking at the effective studies, it's also important to see what we can learn from those studies that did not show any effect. So I have 2 of them listed here. So same author groups. So the first one is on the left: rotator cuff strength is not augmented by blood flow restriction training. Both of these are randomized control trials. One has 35 individuals, the other one has 46. Again, healthy individuals on both accounts, about the same age, same frequency and duration, 2 times per week. So here's where they start to deviate. So on the left-hand side, that first study was done with limb occlusion pressure 80% because it was only the BFR group only applied BFR on the lower extremity. And they did 30, 15, 15, 2, 1, 2, 1 tempo at 30% 1 RM for knee extension and knee flexion. They then did no BFR and they did 2 upper extremity exercises, 3 times 15 at a tempo of 2, 1, 2, 1, 30% 1 RM. Scaption and sideline external rotation were the exercises performed. And so the BFR group, versus the non-BFR group, the only thing that differed was the fact that the BFR group did lower extremity BFR, whereas the non-BFR group did no BFR on the lower extremity, but they both did unoccluded exercise for the upper extremity. And their outcomes were muscle strength and handheld dynamometry in cross-sectional area using the ultrasound. In the subsequent study, again, same group, or at least lead author, this time they did do BFR in the upper extremity, but they only did a single exercise of sideline external rotation. Same outcomes as far as handheld dynamometry and cross-sectional area of ultrasound. So what do you think the results were? And really, what do you think the hypotheses were? So in this first study, right, so they were obviously, they were looking for muscle strength and cross-sectional area, not only on the lower, but also on the upper. So presumably they were considering this to be, questioning whether there was maybe a systemic effect or benefit for doing lower extremity BFR in combination with upper extremity exercises. And then with the second study, obviously there's only one, really one target being the training limb of the upper extremity, and that being a single exercise of BFR. So relatively low volume. So let's talk about the conclusions. So in the first study, both groups significantly increased in their strength gains in lower extremity and rotator cuff strength. There was no between group differences in strength, and neither group increased in their cross-sectional area of their rectus femoris. So the limitations here, right? So no BFR for the upper extremity, and no exercise intensity progression, which may explain the cross-sectional area, or the lack of cross-sectional area in the rectus femoris, and the minimal difference between the group in the groups over time. Conclusion: sideline external rotation with BFR did not increase rotator cuff strength nor supraspinatus thickness versus no BFR. Both groups did improve, but the single exercise of rotator cuff targeting exercises proximal to the cuff, right? What I had been suggesting all the way along is that the studies that show meaningful difference in particularly the proximal muscle groups with the rotator cuff would be considered that you need to have high EMG, you need to have fatigability, and this has usually got to come in the form of we're keeping things low, so the intensity, the mechanical load is really not a variable that we want to adjust for, but time under tension, time under occlusion, the volume of exercises really I think is a key variable in order to increase the EMG activity and promote, which comes secondarily to the fatigue distal to the cuff as you recruit more and more motor units, as shown earlier in the first section of this webinar. And so that's kind of the lesson learned from these two studies as far as the limitations. And if we play out that hypothesis, let's look at a couple studies that showed positive benefits so that we can compare and contrast the methodology and bring better substantiation to this. So Lambert in 2021 looked at blood flow restriction training for the shoulder as a randomized controlled trial of 32 individuals, young again, 25 years of age, plus or minus 1.6 years. They performed it for the exercises 2 times a week for 8 weeks, 50% limb occlusion pressure using the Delphi unit. They used 30, 15, 15 fatigue protocol. That means that last set was taken up to past fatigue until they couldn't do any more. And if they could produce more than 75 repetitions total on 2 consecutive bouts, then they were the exercise was increased by 1 pound. They started at 20% 1 RM isometric. As far as intensity, they used the DEXA for lean body mass. They looked at isometric rotator cuff strength, muscle endurance, and both that endurance test was done for both groups under BFR and non-BFR conditions, and then they looked at muscle EMG across their exercises. The exercises that they looked at, there was 4 of them. So cable external rotation, cable internal rotation, the dumbbell scaption, and then the sideline external rotation. The small asterisks on the first 3 exercises indicate that those were the ones that were used for the isometric rotator cuff endurance as well. Sorry, not endurance, strength for the handheld dynamometry as far as their outcomes. And then they looked at the EMG placement, anterior deltoid, middle delt, posterior delt, teres minor, infraspinatus, and the trapezius, and you can see the placement of the EMG electrodes there. Right, so keep in mind the EMG and the importance that plays on the proximal adaptation. So we have the cable external rotation at 0 degrees. So the black line solid is the occluded, the unoccluded is the dashed line is the unoccluded group, and you can see the number of repetitions across the bottom for the external rotation for the posterior deltoid, the infraspinatus, and the teres minor respectively. The take-home message is that both groups gradually increasing their EMG with a substantial increase almost at every time point in regards to the occluded group versus the unoccluded group. We see similar results for internal rotation on the cable with teres minor and with teres minor having the greatest discrepancy between the 2 groups. And then for dumbbell scaption, we see very similar to that of the external rotation, is that there's a linear increase across all groups, that is muscle groups as well as across both cohorts, but substantially higher and higher EMG relative to baseline as we go across the number of repetitions. So given this information, we can start to, and what we know historically from the other evidence presented today within this presentation, we can start to guesstimate what type of results we shall see, because from a muscle activation standpoint, we can see that a lot of the proximal muscle groups are being activated, and progressively so over the duration of a particular set and across exercises. Changes in internal rotation muscle performance. The other muscle groups didn't show significant changes, but for the internal rotation isometric strength, there was a 14% improvement in the BFR group, none in the occluded group. When it comes to internal rotation strength endurance, so that was occluded versus unoccluded. Regardless of the condition, the BFR group significantly improved their work capacity from baseline by a significant difference, not only from their pre and post, but almost doubling that of the unoccluded group, speaking to the metabolic changes in the muscle endurance capacity, the work capacity of the upper extremity. And then when we look at changes in lean muscle mass, we have upper extremity as well as the shoulder region that they isolated within the DEXA. So there's a significant improvement as shown by the double asterisks, not only pre and post, but also comparably to the control group, the non-BFR group in the lean muscle mass via the DEXA. So once again, we can see that there's a substantial improvement, and there can be a substantial improvement with the BFR application in the upper extremity to the proximal muscle groups, that is the muscle groups of the shoulder in particular, when there's adequate volume and gradual increase in fatigability of the distal muscle groups as well as the proximal muscle groups, as shown by the progressive increase in the EMG over time and over the duration of the exercise protocol. So the conclusions of the study are that using BFR during low load exercises increases whole arm and shoulder muscle mass, increases muscle strength as well as endurance. Responses observed in the shoulder muscle mass as a whole were due to the increase in EMG activity as speculated throughout the discussion of the article. The results provide support for future research on the utility of BFR for rehab in non-operative and post-operative rotator cuff injuries. So when we look at the Lambert study and compared to the Brummett articles previously presented, we can see difference in the results and the conclusions, of course, but we can also see some of the discrepancies and compare and contrast, what was done in the studies that show effectiveness versus those that don't. In this case, right, taking the exercises to exhaustion or fatigue, adding progressive resistance of 1 pound when they hit the 2x2 rule, that is exceeding their target repetition by 2 repetitions on 2 consecutive bouts. And that they're getting not only increased fatigability within the limb, but also within the proximal muscle groups. And that is a recipe for adaptation, as we can see in the endurance, isometric strength, and muscle mass in the whole arm as well as the shoulder muscle mass. Okay, and then the effectiveness and safety of BFR in a post-operative state. So it's a randomized controlled trial of 35 post-operative distal radial fractures. They had 9 females and 23 males, BFR 17 and 18 for the non-BFR group. Rather intense protocol, so 5 times per week for 4 weeks. They use the B-strong cuffs, which we'll speak later as to the limitations that those have. Particularly, they allow for they don't completely occlude the venous system, thus they allow for backflow, particularly with muscle contraction. You can see this on their marketing page. Unfortunately, I don't know why they're marketing it that way. I think that it's intended to be a safety feature, but really it's just a feature that negates the actual benefits of the hypoxic environment and the hyperconcentration of the metabolites distal to the cuff. But no limb personalized occlusion pressure was used, just 120 millimeters. They did it for 4 weeks, as I mentioned, a variety of different exercises, including grip, pinch, isometric wrist extension and flexion, active range of motion, as well as passive range of motion. They took a whole host of different outcomes, including wrist function via subjective outcome measure, pain, looked at wrist, forearm circumference, range of motion, strength. They looked at D-dimer levels as well as radius union scoring system, or known as RUS. And so there were some of the exercises indicated by the article as far as wrist extension against gravity and lying. You can see the passive range of motion and then the isometric wrist extension with the handheld dynamometer. And then that's the B-strong cuff as demonstrated and sported by the individual there. Okay, despite the limitations of the cuff and the lack of individualization of the cuff pressure, the pain scores were linear in fashion and significantly different than that of the non-BFR group, and happened early within 2 weeks and then continued to progress lower than that over 4 weeks. In the middle figure, you have the limb circumference difference, that is from the other side, so this is a symmetry of wrist circumference difference. In the BFR group at 2 weeks versus the no BFR group, there was no difference, and then there was a substantial meaningful difference as the swelling reduced, presumably because you're getting a reduction post-operatively in the post-operative swelling and the size and the girth of the limb and the fluid distension. And then the Cooney modification score, which is the wrist function, surrogate measure of wrist function, we can see that the BFR group almost doubled their scores in comparison to that of the non-BFR group. Well, I take that back. Because of the scaling of the chart, it's not a doubling, but a substantial difference all the same, and that was statistically different from one group to the next. And then, yeah, across the board with the isometric strength, so wrist flexion strength, So no difference at baseline. 2 weeks starting to show a significant difference between the BFR group and the non-BFR group. And again, you're looking at limb symmetry index. I should have mentioned that. So on the y-axis, it's given as a percentage. So they compared the injured limb to the uninjured limb. So at 2 weeks, the individual has regained 50% of their strength, whereas the control group is only at 38%. And then by week 4, they're at 70% of their isometric wrist flexion strength. And we see comparable improvements in the wrist extension as well, almost identical, with 72% improvement met by week 4, and they've cut the difference or the deficit in half by week 2, which is pretty impressive and again statistically significant as indicated by the asterisk sign. So in the postoperative patient, this is showing to be quite beneficial for pain, for their overall their subjective risk score, which I should have mentioned was taken at week 12. So that was a little bit of a later time point, but the wrist strength and the reduction in swelling, despite what some might otherwise consider to be contraindicated in the immobilized limb, is showing to have really nice results here at the wrist. And those are kind of the summary statements, is that BFR therapy can significantly reduce pain, increase muscle strength, and improve muscle function in those individuals seen post-distal radial fractures. BFR therapy did not significantly improve passive range of motion. Further research is needed to determine its ability to decrease swelling. BFR therapy is safe and effective for the distal radial fracture in patients seen post-ORIF, and it does require individualized protocol and frequent assessments. I do kind of raise my eyebrows at the individual protocols because, let's be real, they didn't individualize the pressures. They just kind of used the arbitrary 120 across the board. But that being said, the protocols, it seems, was specific or tailored based upon the patient's response. So really encouraging in at least initial study for the postoperative upper extremity. Okay, and so I won't go as in depth with this article as I have on the previous ones, but I do want to just make sure that I'm giving an adequate pulse on the current literature, and I did spend a decent amount of time talking about the proximal muscle groups and that of the shoulder rotator cuff and the proximal benefits, the cross benefits as well, but I do want to give some love to the elbow, wrist, and hand, and more of the distal clinical trials that have been done. Again, they're a little bit, there's fewer of them rather than the more recent, the first ones that had come out on the upper extremity were around the shoulder. But here's a comparable study, RCT, plaster cast, about the same, about size as that of what we saw in the distal radial fracture. So frequency done at 5 times per week for 6 weeks, 50% LOP, 46 centimeter width cuff, 6 centimeter or 6 week postoperative protocol. What is nice is that they did a lot of exercises. They did 9 exercises: active range of motion, active assisted range of motion, strength exercises. They use a progressive systematic progressive resistance with 1 pound increase per with each of the exercises. The individual could exceed 75 repetitions on 2 consecutive sessions. Their outcomes, they did the patient-reported wrist evaluation questionnaire. They did the range of motion in multiple planes, strength, as well as muscle stiffness. So the conclusions here: individualized BFR therapy can significantly increase subjective rating of wrist function, increase grip strength, increase wrist range of motion, and specifically ulnar deviation. And BFR therapy is safe and effective in the individual that is casted after a Colles fracture, which is really encouraging and consistent with some of the findings that we saw with the ORIF of the distal radial fracture, even though these guys aren't post-op. Again, so we asked the question, so what? A lot of information, a lot of studies. What are the take-home points? Well, what can we learn from the independent studies that we've looked at for the upper extremity? So comparable to that of the systematic reviews, reinforcing the fact that BFR in the upper extremity improves its strength, hypertrophy, and pain with the application of low load resistance training. Particularly emphasis on eccentric muscle contraction if resistance is normalized to an individual's eccentric 1RM, that is. The aspects of exercise may help to enhance the strengthening and muscle performance on the contralateral limb. So in addition to just the immobilization and the ischemic preconditioning that can occur on the immobilized limb, and certainly we saw benefits in the postoperative and the non-operative immobilized limbs in the more recent 2 studies, that this eccentric muscle contraction only really applies if it is adequately dosed. And this also, from a clinical standpoint, and my pro tip for you in your coaching and your clinical practice, is to continue to emphasize muscle activation and volitional activation of the patient during the eccentric contraction, because that's going to almost unanimously be underdosed relative to the concentric. And if we're talking about at least bicep curls, that's going to be at a underdosing of about 60% because of the eccentric to concentric strength discrepancies that exist in that muscle group. And then volume, that is, fatiguing sets are a key variable when wanting to get not only full limb, but also shoulder and proximal muscle adaptations. Multiple exercises greater than 4 in particular show to be beneficial. We saw with the Lambert 2021 article that high boluses of 4 exercises with the fatiguing sets and progressive incremental improvement or increases in resistance help to increase the muscle activation, which seems to be an important prescriptive variable in order to induce proximal muscle hypertrophy, strength, and endurance, and thus the work capacity of the upper extremity in the presence of low load resistance training BFR. And low load BFR is not only safe and effective, but offers significant reductions in pain, increase in muscle strength, and increase in muscle function in the acute postoperative phases of upper extremity BFR rehabilitation compared to a traditional protocol. Yeah, I think that these are really good nuggets. I think that this is I hope that the summary slides, not only this one, but the previous 2 presented, really help to conceptualize and substantiate what the evidence currently is and what implications or applications that this could have in the clinical setting, and hopefully with the patients that you currently see and treat. Okay, and then finally, I'm going to tack this one on here, is what lessons can we learn from the lower extremity BFR studies about upper extremity BFR, and what implications may that have on how we dose and prescribe it and apply it in the upper extremity. So this study here included 16 females. It was they focused on unilateral plantar flexion or heel raises. The cohorts that were included were 25% and 50% 1RM. The individual's opposite limbs served as the control. So one of the calves had blood flow restriction while the other calf did not. Both calves went through the same exercise routine, right? So the duration was 4 weeks, 3 times per week, 5 to 8 minutes per set, and there was 3 sets of as many as they could do to failure of heel raises on one leg and then the opposite. The cadence was standardized 1.5 seconds up and 1.5 seconds down. The outcomes pre and post were isokinetic dynamometer testing, which utilized strength of their 1RM, the isometric max volitional contraction, as well as torque or power at different standardized speeds. They also looked at the blood flow within the calves pre and post. Okay, so let's just get our cohorts straight. So each individual served as their own control, and then they were randomized either to 25% 1RM training or 50% 1RM training. So the black indicates the unoccluded limb for each of the respective percent 1RMs, and then the white bar in the histogram shows the pre and post changes in the 1RM, and you can see on the y-axis that's in kilograms for the occluded limb. What we can see is predictably that if you train someone, let's just focus on the black bars for the instance. So this is the single leg calf raise on the unoccluded limbs. And we can see that we would expect if someone trained it at 25% of their 1RM, or they trained at the 50% 1RM, that the 50% 1RM group would do better, and we see that. And that also mitigates or starts to reduce the discrepancies in the between the limbs, that is between the restricted and the unrestricted limb. However, the restricted limb consistently shows to be superior, specifically when we look at the low intensity 25% 1RM limbs, that the blood flow restriction training shows a 20% increase in superiority in the 1RM relative to the unoccluded limb, which is rather significant. Okay, so same cohorts, just looking at a different outcome. So on the y-axis here, we have change in torque in Newton meters. Once again, we see a significant difference between both limbs, be it the limb that is trained at 25% or that which are trained at 50%. Once again, the blood flow restriction training group being 2 to 3 times that of the unrestricted limb. And if you calculate the difference, it's a 106% difference in the isometric volitional contraction in peak torque. And I think most staggering, for me at least, the big takeaway for this study was the difference in blood flow pre and post. So you're looking at the milliliters per minute per 100 milliunits in regards to the blood flow to the limb. So you have the 25% 1RM and the 50% 1RM, and really there's minimal to no changes pre and post in the unrestricted limbs. However, in the same individuals in the occluded limbs, there's a 43% increase in the blood flow from baseline. And if you look at the difference between the limbs, right, it's like almost 5x, close to 4x that, depending on the group that you look at, as far as the significant difference. And again, the thing that was really profound for me was, one, that this only happened within 4 weeks, and two, it happened within the same individual because the individual acted as their own control in regards to the restricted versus the unrestricted limb. And I think this has large implications. I know it's a lower extremity study, but the regardless of whether we're talking upper extremity or lower extremity, the biological mechanisms of blood flow restriction training are the same, thus potentially influencing the positive adaptations that can occur in the early acute to subacute phases where we can't load people heavy. We can really just fertilize the soil and fertilize the biology in preparation for better response to the high load resistance training that is to come in future sessions. This study was unique in the sense that it looked at the combination of blood flow restriction training as well as NMES. So it took 20 healthy individuals, males and females, 29 years of age. They had 4 groups. They had a control, an NMES, a BFR, and then a combo group. They trained 4 times a week for 6 weeks. The cuff pressure was arbitrarily set at 200 millimeters of mercury. The cuff width was 100 centimeters, which is 100 millimeters in comparison to some of our other studies that looked at 30 millimeter width cuffs. And their inflation was 3 times 4 minutes. So they did 3 rounds of 4 minutes of inflation. They had 2 electrodes. They give the frequency, the pulse length, as well as the intensity of the NMES parameters. For a visualization of it, it looks like this. So there's the NMES is continuous stimulation at maximal tolerable intensity. They did it for 32 minutes, and you can see that the cuff is inflating and deflating respectively with 220 millimeters of mercury for those 4-minute cycles across the duration of the intervention. Yeah, and so what did they find? So their outcomes were muscle strength and muscle hypertrophy. So let's take the first figure. On the y-axis, you have difference in maximal strength in kilograms. So you have the 4 cohorts listed there in the histogram, and you can see the BFR, the NMES, and then the combo group, which would be suggestive of a synergistic effect of the BFR and the NMES, such that 1 + 1 = 3, where there's a superior benefit for the application of NMES with BFR or vice versa, versus the only cohort that didn't really show any significant difference in their strength, and understandably so, is the control group. When we look at the hypertrophy, the changes aren't as vast or as drastic here. Again, it was a 6-week study, but again, there's showing to be, though it wasn't statistically significant, the combo group did edge out the other groups. Granted, you can appreciate the variance that there was with the error bars there. However, into supplement, right, and this is a relatively early study, 2003, I will say in clinical practice that the application of these two modalities really is a synergistic effect. I find that you may not get the hypertrophy effects that you're looking for within the 6-week study that is shown here. And we could talk about and dialogue about the different parameters, right? They only did 32 minutes of exercise within a given training bout, and you may want to do additional exercises, and we could talk about the progressive resistance that may be necessary for the hypertrophy adaptation, so on and so forth. But from a muscle strength standpoint and a muscle performance standpoint, I think it really does give a decent amount of credence to the combination of these modalities. And I have yet to see something of this nature in the upper extremity. So I think that there's untapped potential to be able to take this in science and apply it to the upper extremity individual with BFR. Let's talk about the preservation of muscle mass, particularly in the postoperative patient. So for at least in the lower extremity, the anti-gravity muscle that is inhibited in particular after knee surgery is the quadricep. In the upper extremity, I'm sure that there are comparable muscle groups that also atrophy. I would think that once again, the principles would hold strong for the rotator cuff in the presence of some type of shoulder surgery, potentially a biceps in regards to the elbow, given the anti-gravity, and then though maybe not as visually drastic in the forearm, I'm sure that there are also muscle inhibitions and muscle hypertrophy lost there. The muscle preservation in the lower extremity is of particular importance, and I think it's more dramatic just given the size of the muscle mass. Specifically, I think I mentioned it earlier within this presentation, is that within the first 2 weeks, individuals can drop 350 grams of muscle mass out of their quadriceps, comparable to the 300 grams of a human heart, which is precious real estate that we really, if we can do anything to cut the losses here, I think that we should do so. And so let's kind of consider how blood flow restriction training can somewhat help us in this regard. So this is a post-operative ACL cohort. The subjects, there were 16 of them, 8 and 8, so rather small study, 2-week duration. So they did it immediately after surgery, starting 3 days post-op. The key here is that they did not do any exercise. They had a 90 millimeter width cuff. They pressurized them at 180 millimeters of mercury, increasing 10 millimeters of mercury per day. So there's a kind of a gradual phase up in incremental graded exposure, to which time point that they reached approximately 240 millimeters of mercury. The control group had the cuff on but did not inflate. And then the frequency was performed 2 times per day, and the bolus was for a 25-minute session, right? So you did 5 times 5 minutes with 3-minute rest in between. And so you can see in the histogram here on the y-axis, you have a decrease in cross-sectional area as a percentage of the muscle mass. The experimental group lost around 10% for their extensors and their flexors respectively. The total cross-sectional area decreased around 8%, which really cut in half what was that seen in regards to the control group, where the control group lost almost twice that, which is comparable to what we see. It's consistently seen that the individual can lose about 20% of their muscle mass, and even more than that, almost double that in regards to their strength. post-operatively. And so there was the control group lost 120% greater muscle mass out of their quadricep as compared to the experimental group, thus speaking to the potential value and the preservation that just the occlusion it has, specifically ischemic preconditioning on the important preservation of the muscle mass due to the mechanisms at play and the increased growth factor and hormone release, the blunting of myostatin, which is one of the hormones that also contributes to the significant decrease in the muscle protein synthesis in these rehab individuals. Okay, so in this study they looked at 15 healthy males and they dichotomized them into 3 groups or cohorts. So they had the control group, the isometric group, and then no exercise occlusion group for BFR. Arbitrarily, the pressure was set at 200 millimeters of mercury for the BFR group. The immobilization lasted 2 weeks. So the isometric group, twice a day, they performed their exercises. The BFR group performed the 5x5 protocol, so 5 rounds of 5 minutes of occlusion at 200 millimeters of mercury with 3-minute rest in between 2 times a day, but there was no exercise associated with that. The isometric group, on the other hand, did knee extension in a seated position, knee flexion in a prone position, and then ankle plantar flexion. And all individuals in all 3 groups were casted and encouraged or instructed to use crutches and not be non-weight bearing on the limb for the duration of the 2 weeks. The volume and the intensity of the prescription is shown there in regards to the BFR group as far as the parameters of occlusion as well as the cuff size that was used. The isometric group performed 1 × 20 × 5 second contractions for each of the exercises, again twice a day. So let's take a look at the results. Okay, so here we're looking at muscle preservation and the immobilization in the immobilized limb. So on the y-axis you have the circumference of the muscle loss in centimeters, and they looked at the circumference across 3 different points within the limb. 15 centimeters proximal to the patella, 10 centimeters proximal, and then the thickest part of the calf. The asterisk indicating the significant difference from pre and post was significant for the control as well as the isometric group, specifically at the calf. However, given the isometric exercises and the movements that were associated with the isometric group, there was some preservation of the thigh for both the quadriceps and the hamstrings. But again, the gross nature of the assessment of being circumference rather than DEXA or ideally ultrasound or MRI really doesn't really tell us what muscle groups were associated with the immobilization or with the atrophy specifically. But the significant thing here is that with no exercise, that the BFR group really cut their deficits in half almost at every point across the limb, and even more so in the immobilized portion where it was almost a complete third or 66% loss, more so in the control group as compared to the BFR group, simply just with occlusion. Okay, so what about strength changes? So they looked at 3 different tests of strength, so eccentric as well as concentric, and they did this at eccentric 120 degrees per second, 60 degrees per second, concentric 60 degrees per second, and 120 degrees per second on an isokinetic dynamometer. You can see the percent changes in strength. Obviously, it's an inverted histogram simply because everybody lost strength due to the immobilization. Once again, you can see the asterisks indicating the significant difference in regards to the pre and post changes. The one that stands out kind of is the isometric group with the eccentric of 120. They lost even more than the control group despite doing the isometrics, but in every other strength assessment they were able to preserve their muscle performance. Once again, the really the take-home message here is that even an immobilized individual doing isometrics or just your immobilized individual, that both of those pale in comparison to simply just doing the 5x5 ischemic preconditioning in means of not only preserving muscle mass across the entirety of the limb, but also in the muscle performance of the ankle plantar flexors, which are most dramatically associated with the immobilization. So you're looking at a similar figure here for the knee extensors, pre and post immobilization. So you have on the y-axis the percent change in their strength. They tested them at 6 different means of muscle performance. So the EC stands for eccentric. So they did eccentric 180 and 60 degrees per second respectively in isometric test, and then 3 concentric tests at 60, 180, and 300. The white bars associated with the legend at the bottom are controls, isometric in black, and then the blood flow restriction training in the light gray. You can see that the p-values are associated with each of the different bars. Regardless of the type of muscle contraction, the speed at which it was done, there was no significant difference pre and post for the BFR group that did no exercise for 2 weeks. That being said, there was upwards of 20-25% almost across the board for the control group. A little bit tapering of this for the isometric group, where they had anywhere between 10 and it appears to be about 10% or so loss, with the exception of the faster speed concentric movements of 180 and 300, which is consistent with what you would see, at least what I see in clinical practice, with the faster speeds being more associated with the type 1 muscle fibers as far as the force output is concerned. And oftentimes people post-operatively or after immobilization will struggle more at the slower speed strength assessments and the higher demanding ones, which we see here both with the isometric and the eccentric. And then similar to what we saw with the ankle plantar flexors as well as the knee extensors, we're looking now at the knee flexors, so the hamstrings. Again, they did the same types of muscle tests that they did with the knee extensors for eccentric, isometric, and concentric at the same associated speeds. The results are rather the same. Obviously, what we can discern from this versus the knee extensor strength deficits or changes is that there is a dramatic increase in the muscle loss and the strength loss in the anti-gravity muscles than there are in the knee flexors. And we see this post-operative lower extremity injury as well as in the immobilized individual. Regardless, across the board, there was no significant difference pre and post for the BFR group. And you can even see at time points they were either slightly leaning towards the positive as far as an improvement in strength, which is interesting. But again, not statistically significant. But in each case, we can see that the control group lost the most, isometric group lost secondary to that, and the BFR group pretty much stayed the same across the board. And so similar question that we've asked kind of at each of the different sections of the webinar thus far is, so what are the implications? Why does it matter? How can it change practice? And what are the take-home messages? So what are the lessons that we can learn from some of these seminal studies in the lower extremity in regards to applying the BFR for upper extremity? Well, I think these highlight the power of ischemic preconditioning with the immobilization of the upper extremity and or in the presence of passive range of motion. So there's a preservation of muscle mass, tendon cross-sectional area and stiffness, and even a preservation of the bone mineral density. The metabolic conditioning also, so blood flow restriction training increases the work capacity of the limb via peripheral adaptations of mitochondrial density and function. There's a decrease in pain via the cannabinoid as well as the opioid mechanisms, increased vascularity and increased volume metric blood flow, as we saw that with a 43% increase within an individual. That was the difference between their limbs, between the occluded and the non-included group within a 4-week time point. Really, again, I use the analogy of just fertilizing the soil, setting the biological system up for success in regards to the kind of the subacute phases and the later stages of rehab, where you're going to potentially allow the individual to adapt better to the stimulus that you're going to give them outside of the presence of the occlusion. Yeah, and so the novelty that I think could be applied in the upper extremity that has yet to really come down the pipeline, when we look at the lower extremity BFR studies as exemplars, we see that the upper extremity ergometer is otherwise somewhat underutilized. I know it's utilized in clinical practice from some of the kind of studs in the research realm and those that have presented at CSM and elsewhere on upper extremity BFR, and just significantly improving the work capacity of the upper extremity, even if the healthy limb is doing the movement of the cycle, and the other one is just simply going along for the ride, could provide additional benefits. I think that there's also more evidence coming out now for higher intensity applications with the cycling, as well as with the upper extremity application of the ergometer in the presence of high intensity resistance training as almost a pre-fatiguing state, which we've seen utilized in the lower extremity for some of the higher athletic populations. And those individuals, even if outside of the confines of athletics, those individuals that have a high work demand and high utilization, be it factory workers, be it electricians, so on and so forth, individuals that really are consistently using their upper extremity throughout the day. And then the application of blood flow restriction training in NMES, I think, is an area of further investigation and untapped potential. We see that they're synergistic and complementary to one another, with both modalities combined being superior to any one of either modality in isolation. And then within early rehab, a multifactorial BFR program for the upper extremity, I think, is really indicated. Whether it be BFR in the lower extremity and just improving the overall pain response. We've seen some cross effects as far as doing lower extremity blood flow restriction training and enhancement of low load resistance training on the upper extremity and the improvements there. The application of upper extremity IPC, contralateral lower extremity eccentric BFR, or low load eccentric BFR for the upper extremity, as associated with one of the earlier studies, as I alluded to, as long as the intensity is appropriate for the eccentric 1RM. Again, still light load, relatively speaking, 20 to 30% of that eccentric, and then continuing to coach the individual to volitionally contract through the eccentric portion of the exercise, I think, is imperative. And then finally, the implementation of upper extremity low load resistance training as soon as applicable. And so really starting to push the envelope on this, and I know that they've really started to do this, particularly in the total joint population in the lower extremity, and doing it the ischemic preconditioning even preemptively before surgery to really prep the biological system and improve the patient's response, not only on a peripheral tissue standpoint, but also on a visceral tissue standpoint, and getting they actually recuperate a bit faster and have less reperfusion injuries when they have had the cyclic application of IPC ahead of the surgery. So yeah, I think that there's great application and lessons that can be learned from what evidence exists, even if it's not specific to the upper extremity. And I think that we can start to follow suit in not only certainly immediately in the clinical practice, but certainly looking forward to case series, even case reports, and eventually clinical trials to otherwise prove out the same efficacy of the BFR and some of these combined modalities and strategies in the upper extremity. Okay, and so just checking back in with our objectives that we had set at the beginning of the presentation. So the ones that we've covered thus far is, what is blood flow restriction training? Why would I consider using it? Who can benefit from it? And what does the evidence actually say about the effectiveness of BFR? And that will conclude at least this recording and presentation. The additional 5 bullet points there as far as the objectives will be covered in future videos. Thanks for listening. As always, I welcome questions, comments, feedback, and discussions. And if you want to leave the comment section, that's great. I will also show my references here to follow. Flip through the slides.